Dr. Laura Scorr. I'm a movement disorders neurologist at Emory University School of Medicine. Today about the clinical spectrum of facial spasms, twitches, and other movements. And as I get started, I just want to say a few words about the purpose of this presentation. So this was developed for the Benign Essential Blepharospasm Research Foundation, which is an organization that aims to support research and education on disorders of facial musculature, in particular blepharospasm. Blepharospasm, as you may know, is a rare but particularly disabling condition for which there are actually excellent treatments. So the goal of this talk is to provide some case examples to improve recognition of blepharospasm and to shorten the time from onset of symptoms to treatment of this condition. So with that said, my plan is to provide some introduction about what blepharospasm is, to discuss and show you some of the features of blepharospasm, how it can be differentiated from other facial spasms, twitches, and tics, to discuss how you can make the right diagnosis, and of course the significance of doing so to get these patients the treatment that they need. So to start out with, what is blepharospasm? Blepharospasm is characterized by spasm of the muscles surrounding the eye. It's part of a larger family of diseases, which is called dystonia. And dystonia is a movement disorder caused by and characterized by involuntary muscle contractions causing abnormal, typically patterned, movements and postures. I mentioned that dystonia, or blepharospasm rather, is a relatively rare disorder, but dystonia is actually not all that uncommon. It's the third most common movement disorder, and it affects about 500,000 people in North America. Of those, about 77,000 are estimated to have blepharospasm. Men, women, and children of all ages and backgrounds are affected. This is not a disorder that discriminates, and there are a wide variety of causes for it. In some cases, dystonia may be an inherited genetic abnormality. In some cases, it's due to other health conditions. It can be seen in association with Parkinsonism, for example. It can occur as a side effect of various medical treatments, particularly neuroleptic medications or medicines that are dopamine blocking. Or it can be idiopathic, meaning we just don't know what caused it and can't identify a trigger. And dystonia can really affect any region of the body. I mentioned that when it affects the eyes, we call it blepharospasm, but it can also affect the lower face, the jaw, the voice, the neck, causing twisting postures that are quite painful. It can affect the trunk and the back, even the limbs, all the way down to the toes. And as you might imagine, depending on what part of the body is affected by dystonia, it looks quite different from patient to patient. So if you look here in the upper right, you see a patient with blepharospasm causing her eyes to squeeze shut, and another patient with blepharospasm down here in the middle. These are examples of what dystonia might look like when it affects the neck. This is an example of dystonia causing forced jaw opening. I mentioned it can also affect the trunk or the back, causing an abnormal posture, the limbs or the toes, and to make matters even more complicated, in some cases, dystonia only comes out with certain activities. So one's hand might be completely normal until you try to write, and then you develop an abnormal movement or posture associated with that. Similarly, you can get a musician's dystonia that comes out only when playing your musical instrument, even a golfer's dystonia that might come out only when you're trying to putt. So as you can see, depending on where the dystonia is, it can look quite different from patient to patient. But what patients will tell you with dystonia is that they all have a similar experience. Unfortunately, that's not a great experience. Patients are often misdiagnosed or told that their symptoms are psychiatric. Studies show that the mean time from the onset of symptoms to diagnosis is 4 to 6 years on average. And that's based on recent studies within the last 5 years. And then depression, anxiety, and social withdrawal, unfortunately, are very common in these patients. And that's thought to be not only a reaction to their symptoms, but also related to the underlying disease process in the brain, causing these mood disorders. So you might wonder, it's a disabling disease. It's something that you can see when the patient walks into your office. Why then is there this diagnostic delay? Well, part of it is that diagnosis really relies on clinician exam and pattern recognition. And although dystonia as a whole is not terribly uncommon, blepharospasm is relatively rare. So it's entirely possible to make it through medical school without ever having seen an example of this disease or a patient with this disease. It's also possible to make it through a neurology residency without having seen patients with blepharospasm. And furthermore, clinical features vary quite a bit between patients. So even if you have seen one or two cases, the third case might have a different combination of symptoms and just look different than the other cases you've seen, and can be hard to recognize. And then, of course, it can also be confused with other movement disorders that affect the musculature of the face. So then how do you make the diagnosis? There are some pretty simple clues. One, of course, as I mentioned, it's a movement disorder, so you look for the movement abnormalities. These patients tend to have excessive blinking of their eyelids, also spasms of the muscles around the eye, which can cause squinting or forced lid closure. And then also apraxia of eyelid opening is common in some of these patients. And that's where you see incoordination of the ability to lift up the upper lid. And I'll show you a video example of this as well. Some of the other symptoms that patients report include light sensitivity. So when you talk to the patients, they'll tell you that if they're under bright fluorescent lights or driving into the sunlight, it'll trigger their symptoms or exacerbate their symptoms. Often patients have eye discomfort, such as dryness or irritation. And then there's this thing called a gest antagonist or a sensory trick, which is certainly not present in everyone, but can be quite helpful in making a dystonia diagnosis when it is present. And patients with blepharospasm, typically if they have one of these gests or tricks, it's to touch the skin around their face, or actually in some patients, if they sing, it'll lessen their symptoms temporarily. So rather than just talk about these disorders and tell you what they look like, I thought it would be very helpful to show you some video examples of them so that you can get a sense of what it looks like in real life. Fortunately, many patients have kindly consented to having their exams video recorded for the purposes of education and advocacy for these disorders, but we'd ask you to please not duplicate these videos or post them elsewhere out of respect for the patients. So in this first example, you'll see a patient with blepharospasm who has clearly an increased blink rate. At times, the blinks are happening so rapidly that she doesn't have a chance to completely open her eyes. You'll notice that these movements are pretty patterned and consistent in how they look, and also symmetric in their appearance. And you can see at times when she has these fluttering spells or increased blinking, she can barely hold her eyes open. And you can just imagine how disabling that is for her and similar patients. If they can't open their eyes, they can't drive safely, they can't do their work to maintain their job, and social interactions become so much more difficult for them. That's a typical example. Here's another patient with blepharospasm, but I think you can see already that she looks a bit different than the last patient. But while she does also have an increased blink rate, she has a lot of spasm of muscles surrounding her eyes, causing her to squint, and at times spasms causing her eyes to shut completely. So you can see both of these patients have blepharospasm, but certainly look a bit different from one another. Fortunately, if you can recognize it, they both respond to the same treatment with botulinum toxin, and both of these patients had a really nice response, was able to alleviate their symptoms. So important to recognize this variability, being certainly different, but part of the same disease. And then finally, this is an example of a patient who has apraxia of eyelid opening. So you can see she certainly does not have an increased blink rate, but when she looks over towards the camera and then closes her eyes, although she's being instructed to open them and she's trying really hard to open them, she doesn't have weakness. She's not able to lift her eyes open. And what you'll see in a second is that she has to actually use a sensory trick to open her eyelids. So she pulls a little bit, touching the skin there, and then her eyes come open. You might have noticed as I went through those videos that there's a few different patterns of movement abnormalities patients seem to have. It's certainly not uncommon for patients with blepharospasm to have dystonia in other body regions. You might have noticed in the first two cases they had dystonia affecting their lower face as well. If dystonia spreads, it tends to be within the first 5 years of onset. And typically among patients with blepharospasm, the spread is to adjacent body regions, such as the lower face and the neck. It's actually estimated that half of all patients with blepharospasm will eventually have spread to their lower face. So you shouldn't be concerned if you see abnormal movements in other part of the bodies as well. It could still be blepharospasm. So in summary, the things that you're looking for to make this diagnosis are excessive eyelid blinking, bilateral eye spasms, and occasionally this finding of apraxia with difficulty opening the eyelids. Of course, as I mentioned, it's sometimes present in combination with other movement abnormalities such as dystonia of the lower face or jaw. So hopefully that seems pretty straightforward. You might wonder, what could it really be confused with? One of the most common things that blepharospasm is mistaken for is dry eye. I mentioned earlier that some patients will describe irritation of their eyes, but unlike with dry eye, these symptoms do not get better with re-wetting drops or ophthalmologic treatments. There are a few other movement disorders that affect the face that it can also be confused with, and rather than just describe them to you, I'll show you a few cases of them. So here's one example. This patient has hemifacial spasm. So he does have involuntary eye closure in combination with some spasms of his lower face there. But the key difference here is that the movements aren't symmetrical. It's only affecting one side of his face. And that's the key difference that tells you that, in fact, it's not blepharospasm, but hemifacial spasm. In this next case, even in a still picture, you can see that this patient has spasm of the muscles surrounding her eyes, causing forced eye closure. And really, when you look at patients that have facial tics, it can look almost identical to blepharospasm. They might have these spasms, they might have increased blink rate, but the key difference in differentiating this movement disorder is in the history that the patient gives you. The patients will describe an urge to have these movements, almost like the urge to sneeze. Sometimes they're able to suppress it just for a brief period of time, like you can sometimes hold back or delay a sneeze. But eventually they feel that they have to let the movements out. And some patients will even say that they feel relieved after letting the movements out. And so that's the key difference in the history that you can use to differentiate these facial tics from blepharospasm. This case is perhaps a little bit more subtle. This patient has facial chorea. And again, you can see that he has involuntary movements causing forced eyelid closure. But if you look at his forehead and his eyebrows, what you see is that sometimes the brow furrows, sometimes the eyebrows go down, sometimes the eyebrows go up. And so it's not quite patterned in the same way that we would say blepharospasm is. The movements seem to be flowing from one region of the face to another. And if you were to pan out on this patient, you might actually see movements flowing from one body region to another, even in his limbs, that are not always symmetrical, because this is an example of chorea. This patient actually has Huntington's disease chorea. So again, here the key is looking at whether it's patterned, which it's not totally in this case, and whether it's symmetrical, which it's also not consistently in this case. This is an example of a patient that does have a very patterned and symmetric movement of his lower face. It's rhythmic, it's involuntary, he doesn't have any urge to have these movements. But here the key, of course, is that it's not affecting the muscles around his eyes. So that's the real clue that this is not blepharospasm, it's just a facial tremor, which would be treated differently, of course. And then finally, a disorder that's often mistaken for blepharospasm is lid ptosis. So here you see a patient with involuntary lid closure. You can see his eyes are drifting shut there. If he rests them closed for a moment, he can open them a little wider, but then they begin to drift closed again. So again, it can be confused because it's involuntary lid closure, but here the key difference are that his lids are drifting closed due to weakness. He's not having any muscle spasm in the lids, and if you were to examine him, what you'd actually find is weakness not only in the lids, but often elsewhere in the body, especially on exertion. This patient has myasthenia gravis. And so again, hopefully this is pretty straightforward. Some of the things you can look at or confirm to make sure that it's consistent with blepharospasm and not these other disorders are the symmetry, whether there's any urge associated, which you would not expect with blepharospasm, whether it's pattern, of course it has to involve the eyes, and then whether it's associated with any weakness, which you would not expect with blepharospasm. So this is pretty straightforward. What can we do to do a better job of getting people their diagnosis and the treatment they need more quickly? Well, one thing is to get people more experience with these cases, to show them more cases. This study was published in 2003, and the authors looked at agreement among neurologists on clinical diagnosis of dystonia, in particular blepharospasm. And what they found is that movement disorders doctors who see a lot of these cases got it right and agreed that a patient had blepharospasm when in fact that was their diagnosis. But general neurologists weren't quite as good at making the diagnosis even when the patient had blepharospasm, presumably just because they didn't see as many cases of it in their practice. So one thing that we can do is try to provide better educational materials for doctors in their training and in their practice. And then other things that people are working on include development of algorithms that can help lead doctors to the right diagnosis, development of video-based and wearable technology to identify and measure disease features. This is a particularly hot topic in movement disorders right now and something that we're working on here at Emory. Other groups across the country are working on. And then, of course, there's a lot of interest in biomarkers. Just imagine how wonderful it would be if we had a biomarker in blood. You could do a blood test, make the diagnosis, or even an imaging sequence that could confirm the diagnosis with relatively high sensitivity and specificity. This is another thing that there's a great deal of research effort going into right now to develop good biomarkers. So in summary, hopefully having seen these cases, you have a better sense of the varied clinical features of blepharospasm, the recognition of which is essential for making the diagnosis. You have a sense of how accurate and timely diagnosis is essential to provide appropriate treatment, and treatment is, of course, essential to improve quality of life in these patients. So with that said, I just want to thank the patients that kindly consented to have their videos recorded for the purposes of education and advocacy, my clinical colleagues and research mentors, including Dr. Jinnah and Dr. Factor, the Dystonia Medical Research Foundation, who provided me with funding support for fellowship focused on dystonia, and the Benign Essential Blepharospasm Foundation for their advocacy for patients with blepharospasm and for supporting this video project. These are some references, and if you find that you have questions or are interested in learning more about blepharospasm, I'd encourage you to visit the website of the BEBRF that you can see here to learn more. Thank you.